Okay. So my presentation is entitled People Are Dying, Move Fast, and God Bless Everyone, Chloroquine Toxicity in the Age of Coronavirus. And in case you hadn't heard the quote before, that is my title, that is from President Trump's Twitter feed when he was talking about how great chloroquine and hydroxychloroquine can be. Okay, this is just a disclosure statement because we do get support for the Pediatric Environmental Health Specialty Units. Here, if you have further interest in PASU and pediatrics and environmental health, you can go to this website, pasu.net/nationalclassroom.html. All right, so some learning objectives for today. So regarding hydroxychloroquine and chloroquine, we are going to understand the theory behind their proposed use for a variety of different purposes. We will appreciate their potential for toxicity. Mostly we'll focus on acute toxicity today, but we'll talk a little bit about chronic issues. And then we'll describe the clinical presentation and the treatment of a severely poisoned patient. All right, so some pretest questions. Number 1, chloroquine and hydroxychloroquine are FDA approved for what use or uses? And I know you guys are all muted right now, but just, answer in your mind. And if you couldn't decide between malaria, lupus, and rheumatoid arthritis, you're correct. So both of these medications are approved for malaria, although chloroquine is probably more commonly used for malaria treatment if it's in areas where there's resistance. Chloroquine is also FDA approved for malaria prophylaxis and for non-intestinal amoebic infections. And then it's used off-label for a variety of issues. And then hydroxychloroquine is FDA approved for malaria as well as lupus, which is why there's a picture of the wolf there, Canis lupus, nerd joke. And also it's FDA approved for rheumatoid arthritis. All right, so chloroquine does have a narrow therapeutic index, and thus it has a high potential for toxicity. So that leads us to pretest question number 2. Is this news or fake news, aka true or false? Hydroxychloroquine is 2 to 3 times more dangerous in overdose than chloroquine. And the answer is that was fake news. And the truth is that chloroquine is actually 2 to 3 times more toxic than hydroxychloroquine. This is based on animal studies, so we're extrapolating to humans, but experience would suggest that chloroquine is more dangerous. Pretest question number 3. A patient with severe chloroquine toxicity may manifest which of the following signs or symptoms? A, respiratory depression and apnea, B, hypotension, C, QRS widening, QT prolongation and dysrhythmias, D, seizures, E, profound hypokalemia, or F, all of the above. And for you guys who are good at test-taking strategies, if you said F, all of the above, you are correct. So these medications in acute overdose are very scary, very dangerous, and patients decompensate very quickly. And that's why we're talking about them today. So here's our outline of our discussion today. We'll be going over some background information, some potential mechanisms of action for why these medications can be used to treat not only malaria, but also other diseases like inflammatory conditions and viruses. We'll take a look at what we've been seeing in the news lately and then talk about toxicity and treatment options. All right, first a little bit of background. So chloroquine is a synthetic weakly alkaline analog of quinine. Quinine is plant-derived from the cinchona tree, in South America, and because it's from a plant, there's just a limited supply of it, and that's why quinidine and eventually chloroquine were eventually created. And you can see, well, what would a toxicology lecture be without some chemical structure? So you can see on the left there, the bottom left has a structure of quinine, and next to it is the class 1A antidysrhythmic quinidine. And then up at the top, the larger one, that's chloroquine. And you can see the structures are all fairly similar. So in 1934, a chemist at Bayer Pharmaceuticals developed chloroquine as an antimalarial agent. So this has been around for a really long time, but chloroquine was felt to be too toxic for practical use in humans. And so it sort of fell out of the spotlight for a while. But in 1945, it was rediscovered, and it became a first-line treatment for malaria. In 1953, the FDA granted it approval for use in the U.S. for malaria, and it's also on the World Health Organization's list of essential medications for malaria and rheumatoid arthritis. And just briefly, hydroxychloroquine, again, it's 2 to 3 times less toxic. Chloroquine is the more toxic agent. In 1955, hydroxychloroquine was FDA approved for use in the U.S., and it also is on the World Health Organization's list of essential medication, specifically for rheumatoid arthritis, although it can be used for malaria treatment and prophylaxis, but it is better really as an anti-inflammatory than is chloroquine, and so it's more commonly used for those reasons. Okay, so from this point on, I'm going to mostly just use the word chloroquine, but keep in mind that chloroquine and hydroxychloroquine are very similar, and so really this is just for ease of use. So anytime you hear me say chloroquine, just think to yourself chloroquine and hydroxychloroquine. So we're going to talk about their mechanisms of action. Hang on, I'm having some technical issues here. Okay, so the mechanism of action as an antimalarial. So chloroquine concentrates in the cell, in the human cell, in the vacuoles that Plasmodium uses for food. It ends up interfering with heme metabolism that Plasmodium would usually do, and so the parasite becomes unable to detoxify heme. This causes the accumulation of toxic heme byproducts, and that causes the parasite to die. All right, what about the mechanism of action of the DMARD, a disease-modifying anti-rheumatic drug? So chloroquine has anti-inflammatory properties that, like many mechanisms of actions for pharmaceuticals, are not completely understood. It might interfere with lysosomal acidification and antigen processing, and it probably impairs various mediators of autoinflammation on neutrophils like TNF-alpha and IL-6. And this is why we use it for a lot of autoimmune diseases. All right, what everyone is interested is what are the mechanisms of action for chloroquine's use as an antiviral agent. So, we'll talk about some mechanisms, but again, the mechanism is really only partially understood. Chloroquine has been shown to have some in vitro activity versus a variety of different viruses, including HIV, hepatitis B, herpes simplex, and SARS. And it has been used to treat SARS, MERS, Ebola, and other viruses. To super simplify this, one mechanism is that it collects in and inhibits the vesicle function of vesicles inside cells. It makes these vesicles more alkaline when normally they would be acidic. This includes endosomes. And endosomes are a type of vesicle that viruses use to enter cells. So if the endosomes are non-functional because of chloroquine, then it prevents the virus from entering the cell at all. This isn't the only mechanism of action, though, because chloroquine has been used during different stages of viral replication and has still shown some efficacy. One paper I found online, it hasn't been peer-reviewed or published yet, so, take it with a grain of salt, but it was theorizing because they had found evidence that the virus, COVID-19 specifically, interferes with, or SARS-CoV-2 specifically, I should say, interferes with hemoglobin's function and with hemoglobin's ability to carry oxygen. And so these authors were hypothesizing that since chloroquine also alters hemoglobin, like how we were talking about for malaria, that this could be part of its antiviral mechanism. Again, this hasn't been peer-reviewed or published yet, so it'll be interesting to see if we hear more about that type of mechanism in the coming weeks. Another thought is kind of separate from strictly antiviral activity, and that's that perhaps the anti-inflammatory effects of chloroquine that we discussed can help mediate some of the disease complications. Let's move on to what's been trending in the news lately. So the World Health Organization did put out a position statement on the use of chloroquine in the context of COVID-19. And basically, they were just saying that there are a lot of clinical trials ongoing, and currently there's insufficient data to assess the efficacy of the medication in this specific treatment for COVID-19 or in prevention. Moving a little closer to home, the Centers for Disease Control also put out some statements. Basically, they were saying that chloroquine and hydroxychloroquine have been shown to have in vitro activity against coronaviruses, including the one that causes COVID-19, which is SARS-CoV-2. They did reference some articles, which we'll talk about a bit more later on, one of which showed that chloroquine-treated patients had clinical improvement, thus chloroquine use is recommended in China. One showed that hydroxychloroquine resulted in decreased viral load and that effect was improved with azithromycin co-administration. This was a small study out of France, only 20 patients were treated. And then there are multiple US trials ongoing to assess hydroxychloroquine because that's easier to get in the US than chloroquine. It's used for prevention and treatment. All right, so after the CDC put out their news release, the FDA put out its own news release as well, just saying that they have been working closely to look further into chloroquine and hydroxychloroquine's use. Then later on, the Texas State Board of Pharmacy put out a temporary rule, and this is mostly to prevent hoarding of these drugs. And their temporary rule limits prescriptions for chloroquine, hydroxychloroquine, the related compound methylquine, and also azithromycin. It specifically states that the patient on their prescription must have a written diagnosis consistent with the evidence for its use. A little vague there. And it can be only a maximum of a 14-day supply for a new prescription, and no refills are allowed. Other states have also limited prescriptions in similar manners. Some include Idaho, Nevada, Ohio, Utah. And again, this is all to prevent hoarding because we are seeing reports of that as well. All right, so on March 21st, President Trump tweeted that hydroxychloroquine and azithromycin taken together have a real chance to be one of the biggest game changers in the history of medicine. The FDA has moved mountains, thank you. Hopefully they will both, H works better with A, International Journal of Antimicrobial Agents, be put in use immediately. People are dying, move fast, and God bless everyone. And so, as his tweets often do, we saw a lot of news responses. One was from the New York Times. There was something out of the BBC. You know, a lot of people are reporting in the media on COVID and chloroquine. What is the actual data showing us? All right, so we have a few articles here. Again, a ton of articles are ongoing, studies are ongoing right now. So this is all in development. But one article from Gautret et al. Looked at multiple patients and they had 3 arms of their trial. 6 of those patients were in the hydroxychloroquine plus azithromycin arm, and these patients, after being treated with 6 days of both medications, had 100% viral clearance in their samples. This study has been criticized because it didn't evaluate clinical outcomes, and of course because it's small. With hydroxychloroquine alone, they had a rate of 57% viral clearance, and then for those who did not receive any hydroxychloroquine, the rate of viral clearance was only 12.5%. There was another study by Chen et al., and this was 30 patients, and they found that there was no clinical outcome difference between hydroxychloroquine and usual care. So again, 30 patients, 2 arms, still a very small study, no difference between the 2. And then another study by Molina et al. Looked at 11 patients. All 11 of them received, it was kind of a case, I guess, all 11 of them received the same regimen of hydroxychloroquine plus azithromycin as that Gautret study. And they found that 80% of their patients, which really is just 8 patients, they were only able to test 10 patients because one of them died. But anyway, 80% of their patients did not have viral clearance on day 6. So this is different from the Gautret study. And then they found no evidence of strong antiviral activity or clinical benefit. And I know there are other studies. I'm seeing commenters. Thank you. So there's a lot of information in development, and many other clinical trials are ongoing. But right now, it seems that the answer is just not clear. We just don't have the data yet. Okay, but because of all these studies, unfortunately, people have, as I mentioned, started to hoard chloroquine, and that includes even buying chloroquine from non-pharmaceutical, or at least non-human pharmaceutical sources, including pet stores. Certain aquarium cleaners are contain chloroquine phosphate in them, and you can buy them relatively cheaply and in very large amounts. So pet stores are running out of this chloroquine phosphate fish tank additive. The FDA actually ended up putting out a letter to stakeholders, as they call it, saying do not use chloroquine phosphate intended for fish as treatment for COVID-19 in humans. And then the World Health Organization also put out a statement saying that they were concerned by reports of individuals self-medicating with chloroquine and causing themselves serious harm. And unfortunately, there are multiple reports of serious harm. In Nigeria, there were multiple poisonings, and their version of the CDC put out a statement of do not engage in self-medication. This will cause harm and can lead to death. And indeed, an Arizona couple unfortunately did find some fish tank additive with chloroquine phosphate in their closet. And after seeing it on the news, the husband and wife both took the fish tank medication, and the husband died. In Sweden, some hospitals have actually stopped using chloroquine to treat COVID-19 because of reports of severe side effects. So after all of this, the CDC put out a Health Alert Network advisory. saying severe illness is associated with using non-pharmaceutical chloroquine phosphate to prevent and treat COVID-19. And they state that the public should only take chloroquine under the supervision of a healthcare provider as a prescribed medication. There's also a joint position statement from the AACT, the ACMT, and the AAPCC, cautioning users of toxicity from hydroxychloroquine and chloroquine. Nevertheless, on March 28th, the FDA put out an emergency use authorization regarding chloroquine and its use in COVID-19 patients. This is not the same as FDA approval, it's a bit different. It does acknowledge the lack of evidence supporting the efficacy of these medications, but it acknowledges that chloroquine might be effective, whereas COVID-19 infection can be quite deadly, and we really have no alternative treatment at this time. And so the emergency use authorization specifically authorizes prescriptions of chloroquine for adults and adolescents who are hospitalized, weigh over 50 kilos, and who cannot participate in a clinical trial. Ooh, all right, so a lot in the news. Let's move on to toxicity. So first we'll talk about some adverse effects with therapeutic use, and then some drug-drug interactions, and then we'll talk about acute overdose as well. So first, adverse effects with therapeutic use. There can be a lot. You know, most of these are fairly rare, and these are just some of the more serious ones to watch out for and just monitor in your patients. Remembering that all pharmaceuticals have potential adverse effects, even with therapeutic use. This is always going to be a risk-benefit decision. So cardiac effects include conduction blocks, cardiomyopathy, and heart failure. Endocrine effects include hypoglycemia. This is for diabetics and also non-diabetics, but especially keep this in mind for your patients who are on sulfonylureas. Hematologic effects include hemolytic anemia and methemoglobinemia. This is especially true for patients who might be more prone to oxidative stress because chloroquine is an oxidant. So this would be like your G6PD deficient patients. Neurologic effects include extrapyramidal symptoms, neuromyopathies, and seizures, so be careful if your patients already have a low seizure threshold. And then with chronic use, a patient can get irreversible retinopathy, and so routine eye exams are recommended for patients on chronic use. It's also important to keep in mind that patients with chronic kidney disease overall are at higher risk for adverse effects because chloroquine is largely renally eliminated. All right, we'll talk about some drug-drug interactions. So chloroquine definitely causes some cardiac effects as we just went over, so be careful if your patient is on antidysrhythmics. There's a potential for interaction there. As I mentioned, if your patient's on anti-hypoglycemics, in particular sulfonylureas, just be sure they're monitoring their blood sugar very closely. Chloroquine is partially metabolized in the liver and is a major substrate of cytochrome P450 isoenzymes 3A4 and 2D6. So if they are on CYP inhibitors, then there's the risk for an increased level of chloroquine in the body. And so some examples of 3A4 inhibitors would be a lot of the antiretrovirals, clarithromycin, amiodarone, diltiazem, verapamil. And some of the 2D6 inhibitors would include bupropion, fluoxetine, paroxetine. So there are a lot. And then, of course, QT prolonging agents are something to worry about as well. So a lot of antidepressants are QT prolonging, methadone, ziprasidone, and perhaps most pertinently, azithromycin. And again, these aren't too common, but it's definitely something to keep your eye out for your patients who are being treated. So let's go over an example case. You have a 50-year-old female brought in by EMS after an overdose. 30 minutes ago, she put powdered aquarium cleaner in a glass of water and drank it because she heard it could prevent coronavirus. She had dizziness with nausea and called 911. EMS tried to have her drink charcoal, but she started seizing, so they gave her lorazepam 2 milligrams IV instead. And she arrives to your facility where her heart rate is 50, her blood pressure is 88/48, respirations 12, and temperature 37. On exam, you note some mild somnolence and confusion. An initial labs show hypokalemia with a potassium of 1.8 and the rhythm strip below. All right, so what's happening in this patient? I'm sure you guys guessed it. This is a talk about chloroquine toxicity after all. This patient is chloroquine toxic. So we'll just do a quick overview of acute chloroquine toxicity. Chloroquine has a very small toxic to therapeutic margin. So this means that the toxic dose is not much more than the therapeutic dose. And in fact, in a child, 1 to 2 tablets can be lethal. And in an adult, 3 to 5 times the therapeutic dose can be lethal. So potentially 10 tablets could be fatal for an adult. Chloroquine is rapidly absorbed from the GI tract and fairly completely absorbed from the GI tract, and this causes very early onset of symptoms. Within 1 to 3 hours, they could be crashing. These patients have a precipitous decline with CNS depression, seizures, apnea, and cardiovascular collapse. Some markers of severe poisoning include if the patient has ingested greater than 5 grams for an adult, or for a child over 30 milligrams per kilogram, although some fatalities have actually been reported lower than that, 2.25 grams for an adult and 27 mg per kg for pediatrics. Other markers of severe poisoning would be if the blood pressure systolic less than 80, if the QRS is greater than 120 milliseconds, if the patient is hypokalemic, that actually correlates with the degree of toxicity. And then, of course, if they have ventricular dysrhythmias like VFib, that's a marker of severe poisoning, as I'm sure you could figure out. So let's talk specifically about cardiovascular toxicity for a minute. Chloroquine causes both sodium and potassium channel blockade. This leads to hypotension and dysrhythmias. Some specific EKG changes you'll see would be QRS widening, AV block, ST and T wave depression, U waves, and of course QT prolongation leading to torsade de plante. Chloroquine also causes potassium to shift into the cells, and as I mentioned, the degree of hypokalemia correlates with the degree of toxicity. Here is an EKG of, this isn't specific to chloroquine, but this is an overdose of a sodium channel blocking agent. So you can see the widened QRS and the prolonged QT. You also can see the tall R wave, R prime wave actually in AVR, and the deep S wave in lead 1. We'll talk a little bit about neurologic toxicity. So again, sodium channel blockade happens not just in the heart, but also in the nerves. And this can cause dizziness and headache, CNS depression, and seizures. And with chronic dosing, you can also have irreversible ophthalmologic and ototoxicity. That's even with therapeutic dosing. All right, let's go over the treatment. So back to our case, we have this very sick, bradycardic, hypotensive, CNS depressed, hypokalemic patient with an EKG that shows QRS widening and QT prolongation. What do? So starting with our summary, we want to focus on the ABCs of emergency medicine: airway, breathing, circulation. So this includes early intubation and epinephrine, and we really are going to focus on those two things. We'll talk about high-dose diazepam, which has been put out as a possibility to treat chloroquine overdose, and we'll talk about some adjuncts you could consider like activated charcoal, sodium bicarb, and potassium. All right, early intubation. This is something you want to do for any CNS depression. Again, these patients can decompensate early after their overdose, and they can decompensate precipitously. So you want to get them intubated before their blood pressure drops. Epinephrine. So again, these patients can be hypotensive, and that sodium channel blockade can really cause a lot of decreased inotropy. And so we want to choose a pressor agent that is going to increase inotropic activity. So epinephrine would be a good choice. It's available in many EDs pre-mixed already. If it's not available in your ED, consider having your pharmacist start supplying it in your Pyxis for you. We want to start epinephrine in this setting a much higher dose than a lot of us are used to. Usually we use epinephrine and other pressors for septic shock. And epinephrine, the usual dosing for that, you might start at 0.05 or so mics per kg per minute. In this setting, though, we're going to start 5 times higher than that. We're going to start at 0.25 micrograms per kilogram per minute. And then every 10 minutes, you can increase that by another 0.25 mics per kg per minute. And of course, this is because epinephrine has a lot of beta agonism, so that'll help with our inotropy. It does have some alpha agonism as well. So if you feel like your patient's getting too vasoconstricted, you might consider switching to a pure beta agonist. And the awesome thing about today's world is a lot of us have bedside ultrasound, so you can use that to help titrate and make sure that you are getting enough inotropic support. Let's talk about diazepam. So one thing you might read about in the literature is the use of high-dose diazepam. And this is going to be specifically 2 milligrams per kilogram IV given over 30 minutes. And then a maintenance dose of 2 milligrams per kilogram per day, usually for several days. And so keep in mind, in an adult patient, if we assume 70 kilograms, 2 mg per kg right off the bat, that's going to be 140 milligrams of diazepam. So quite a lot. So you might have to intubate just for that reason alone, if you weren't intubating already. But unfortunately, with high-dose diazepam in this setting, there's conflicting efficacy data. Most of the data is from pig, dog, and rat studies, just animal studies. There are also case reports and some retrospective studies in humans. And then prospective studies really haven't shown much efficacy over airway and inotropic support. So, I know there are national drug shortages. A lot of you might not have very much diazepam available to you. And so really, this is something to consider in your chloroquine tox patients. But if you can't do it, don't worry about it. Really focus on the airway management and the inotropic support. Let's go over some other adjuncts that we can use. So firstly, activated charcoal. I put a question mark here because, the pendulum on activated charcoal's use has really swung back and forth a lot over the past. Chloroquine and hydroxychloroquine are well absorbed, but these patients are at very high risk for airway compromise. And so you would hate to have someone drink charcoal and then decompensate, become CNS depressed, and potentially aspirate, and your view could be obscured when you're trying to intubate. So, it's something to consider, but use very judiciously. Sodium bicarbonate. So this is a sodium channel blocker overdose, and for most overdoses with sodium channel blockers, we want to give sodium bicarb. This treats QRS widening caused by sodium channel blockade. Unfortunately, it worsens hypokalemia, and as we mentioned, chloroquine can cause severe hypokalemia because of shift into the cells. So keep a real close eye on that potassium when you're giving sodium bicarb. The dose is going to be a bolus of 1 to 2 milliequivalents per kilo, just like with any other sodium channel blocking agent. And then you can repeat that as needed when their QRS widens back out again. That's what the literature best supports. I know some people will start a drip after the bolus and just titrate it to narrow the QRS. This can be easier on the staff. Sometimes it might be sort of an easier way to implement that, but again, the best data supports the bolus dosing. All right, potassium supplementation. So we have all these reasons for the patient to be hypokalemic. We have the chloroquine toxicity itself, we have the sodium bicarbonate, and plus, we mentioned we're putting them on high-dose epinephrine. That's going to shift the potassium into the cells as well. So your patient could be very critically hypokalemic. Generally, we like to say replete the potassium when it is less than 2. Patients are going to be prone to dysrhythmias from hypokalemia. Generally, hypokalemia is better tolerated overall than hyperkalemia. And when you're repleting, just don't forget to give magnesium with it to help your body hold on to the potassium. And the reason we're waiting for the potassium to get so low is because it's not a total body hypokalemia. It is because of intracellular shift. And so we're trying to prepare for when the patient is starting to recover. We don't want to have redistribution hyperkalemia. Otherwise, you can treat supportively. These patients may need benzos for seizures. If they have wide complex tachycardia, you could consider lidocaine. If they have torsade de pointe, you could consider magnesium, overdrive pacing, that sort of thing. So again, here's our overview, remembering that a small dose can be very toxic. It happens early. These patients decline fast, and some markers of severe poisoning, which for the most part are fairly intuitive: low blood pressure, wide QRS, dysrhythmias, and severe hypokalemia. And again, our treatment summary: early intubation, epinephrine, diazepam maybe, plus or minus adjuncts. Really focus on those ABCs of emergency medicine, and you will do a good job for taking care of your patient. Some take-home points from my presentation today. Chloroquine may or may not help COVID-19. We're just not sure yet. Jury's still out, but a lot of studies are ongoing right now. So hopefully we'll have a better idea in the near future. Per the FDA Emergency Use Authorization, we can consider these medications for hospitalized patients with those caveats I mentioned before. Closely monitor these patients' EKGs and their blood sugars, and you may need to adjust their home medication. And then for acute chloroquine toxicity, focus on those ABCs of emergency medicine, consider use of diazepam and adjuncts, and as always, call your local poison center. We are free and open 24/7, and we are happy to help. We love talking about toxicology, so give us a call. Here, I think I see a question. So I see Dr. Kazi mentions a recent article. So that's awesome. And Dr. Kazi, if you would like to expand on that, that would be great. And Dr. Kazi, if you want to tell us about your case in Lebanon, that would be great.
Thank you for this great presentation. It's very timely, very thorough. And just wanted to share a couple of things. I received yesterday a Twitter feed about the retraction of, or not a retraction, a concern about the Raoul patient study on chloroquine in France that you also mentioned and criticized. So there's already a retract watch about this. I tweeted it on my Twitter account. You can see it. Because of this study was an open label, non-randomized trial with a lot of limitations and concerns with some people about its validity. And the other thing I wanted to share was we just had a case last week, Dr. Sara Watkins and myself in Beirut, American University of Beirut, a 15-year-old child with COVID-19 and a history of cerebral palsy received a supratherapeutic dose. It received a 10-fold dose instead of 300 milligrams, ended up getting 3 grams. Luckily, this child was okay. Of course, the neurologic status was difficult to assess because of the baseline neurologic condition. One thing that we noted that was interesting, the QTC prolonged to 506 milliseconds 14 hours later, not until 14 hours. We thought that was a little bit delayed. The potassium stayed above 3, so we did not have to do any potassium repletion or any interventions, and the child ended up doing okay within 32 hours. So, one last question for you. Has anyone seen any data on how high has the epinephrine dose gone up to? I know we start pretty high, but how high have we gone up to with these cases? If anyone has information, that'd be great.
I don't have those numbers in front of me, but Dr. Boren, I know that you've done some research on this. Do you have any numbers in your mind offhand?
I was trying to recall, we saw a number of cases when I was in France, and I remember that there were some pretty high doses of epinephrine, but I honestly don't remember what kind of maximum dose there was, if there really was a maximum. I think they just increased it as long as the blood pressure was unstable or there was hemodynamic instability, but I don't remember a maximum dose.
I was looking at the study published in the 80s by one of your colleagues, Dr. Boren. This is maybe when the person you were working with, Dr. Frederic Beau in Paris. And unfortunately, in that study that's published in New England Journal of Medicine, there's no mention of the epinephrine range that was used. They do say that they used it, but they don't give us a range, unfortunately. I wonder whether we can get the original data from that study would be useful.
I could certainly contact Frederick and see if he recalls the maximum doses. I'm sure he would. He's got a pretty good memory. But I could talk with him or try to talk with someone else there who was there at Ternavida. So I'll see what I can do.
We've also considered, the issue with propylene glycol as a diluent and lorazepam and diazepam. So we consider that as well as potential toxicity in these high dose infusions for 2 or 3 days.
Absolutely.
I see some other questions on the chat. Let's see. So there's one about, have you ever seen any cases where instead of using bicarb, hypertonic saline was used to avoid the bicarb potassium shift problem? I have not seen any cases of that. That's a great question, and I think that's a really interesting idea that might be worth looking into and seeing if that's something that could be done. Another question here, if we're trying high-dose benzodiazepine, but there's a diazepam shortage, is there any evidence to support use of high-dose midazolam or lorazepam? So the mechanism that's proposed with using diazepam as almost an antidote is that it binds to and acts on benzodiazepine receptors in the periphery, specifically on the heart. And so, in theory, any benzodiazepine could work, but I think the data really has just been, studies have really just been done with diazepam, and I don't know why that is. I don't know if it's because diazepam is the oldest or most widely available of those drugs. When I was doing this research, I did see a proposed dose of midazolam. I didn't see anything about lorazepam, though.
I think when most of these studies done, midazolam was really not available in France. Most of the work that's been done has been done in Africa and France. and I don't think midazolam was available then. Lorazepam is not widely used in France, to my recollection.
Another question in the chat is, in the pretend patient that we discussed, would we intubate with those vitals? So she was bradycardic, a little bradycardic at 50, and she was hypotensive in 80s. And the question is, would you intubate with those vital signs, or would you try some resuscitation before intubation? And I think from my perspective, resuscitation before intubation is always going to be your best course of action. You do not want to have a peri-intubation cardiac arrest, and RSI meds, many of them that we give, will cause, vasodilation and vasoplegia and further lower the blood pressure. So I would definitely consider starting peripheral epinephrine beforehand, and maybe push a few amps of bicarb as well, and try to optimize as much as possible.
Yes, thank you. Regarding the midazolam, we had a case in several years ago in Atlanta, like Grady, in 2015, I believe. This was a 22-year-old woman who overdosed on 6 grams of hydroxychloroquine. And in this woman, we ended up giving midazolam 10 milligrams per hour infusion. She had a wide QRS, and she had also hypokalemia. Ended up requiring 290 milliequivalents of potassium chloride total over about, I believe it was about 12 to 14 hours. Just keep in mind, how you are going to deplete this potassium rapidly. This may be an issue with the rate limitation for potassium chloride IV. But in that case, we did use midazolam. We used bicarbonate for the QRS, and then we had a rebound of the potassium to 5.6 at the end.
Thank you for that. Another question is, it seems like inclusion criteria for hydroxychloroquine includes advanced disease, and at that point, it doesn't seem like antiviral properties would help the patient much, and the anti-inflammatory properties may be too little too late in an ARDS type picture. If COVID-19 is largely mediated by IL-6, are we studying the effect of hydroxychloroquine earlier in the disease process? This is something where I know there are just a ton of studies ongoing, but I do think they're mostly hospitalized patients, and so you make a great point, which is that, the hospitalized patients are usually pretty progressed in their disease process. So, and there is a shortage of hydroxychloroquine as well. So I'm not sure if anyone is studying hydroxychloroquine earlier in the disease process. I have read that people are looking into if patients who are chronically treated with these medications, like people with lupus and other autoimmune diseases, if they have less of a risk for severe disease. So that might be illuminating. Okay, I think that's all the questions from the chat. If there are any other comments, we can address those, but otherwise I think we can move on. Thank you, everyone.